Today we're going to talk a little bit about controversy. And one of the issues that I think we all have to deal with is what is real, what's not real. What are the controversies out there that people have? What are the agendas that people have that they're pushing one thing versus another? How much of that is in the literature? How much evidence is behind a lot of these thought processes? And how much is it that just clinical practice has driven itself into these areas? And so controversy is always a fun thing to look at. And so let's start with a whole issue of controversies that have really been flooding the continuous formats, if you will. So the first, I think, is that the dialysate needs to be sterile. Is that true? Do dialysate deliveries in the form of dialysis really need to be sterile? In intermittent forms of therapy, for acute renal failure, it isn't. In continuous forms of therapy, there are those who say it should be because of back filtration of biofiltrable dysfunctional units like LAL-positive materials. Yet we've been practicing with not sterile but ultra-pure dialysate for more than 10, 12 years, not had a problem. So there's a controversy whether it should be sterile, can membranes sterilize it, or do you need to have heat sterilization? Big issue. Second, what should that base equivalent be? Should it be bicarbonate or can it be lactate? Are there restrictions with the use of lactate as a bicarb equivalent, or should you just use bicarb? Are there outcome variations with that? Theories, not really much in the way of evidence, one versus the other. A third, a method of choice of therapy. Hemofiltration, hemodiafiltration, hemodialysis. We can't even see whether or not continuous therapy, and we'll see that, has an advantage over intermittent therapy, and yet we're going to now further break this down and say hemofiltration is better than hemodialysis, or hemodiafiltration has the elements of both and is the best form of therapy. I think a lot of this has come from intermittent forms of therapy where that's true, that hemodiafiltration probably is better than hemodialysis. But in the continuous forms of therapy, it probably isn't as true. Again, a controversial issue. The whole idea of pre-dilution versus post-dilution versus both. Pre-dilution is supposed to decrease the clotting elements that you would have in your system. Post-dilution is supposed to be the most efficient form of therapy. So if you did both pre and post, you would have the efficiency and lower clotting. Is that true? Never been subjected to prospective, randomized controlled trials. All theory. And then finally, which anticoagulation method is better? So that whole issue of outcome controversies are important. If we move on a bit and we focus on therapies, where do you focus your therapy? Do you focus it on solutes? Is it what form of solute? Is it urea or something else? Do you focus it on volume? Is volume an issue that's coming up as a comorbid event that creates morbidity and perhaps has a hand in mortality? If we look at initiation, do we start earlier? Do we start later? Is earlier going to add anything? Are we focusing only on renal dysfunction? Are we focusing on systematic dysfunction with an earlier start, not necessarily with renal, but more with other organs? As we talk about length of therapy, we did discuss this in dose number 2, where we looked at whether or not a dose higher than 1.2 3 times a week in intermittent or higher than 20 mils per kg per hour in continuous carried with it any advantage in outcome over those particular starting points. And we found that there were none. If we move on to the form of therapy, the dose of therapy, we've just seen a good prospective study showing that dose after a specific area, in other words, once you're above a floor of 1.2 kT/V on intermittent, 3 times a week, or a continuous form of therapy at 20 mils per kg per hour, beyond that, there's no real need to go higher. That's been pretty well definitively stated in a very good prospective study. It needs to be repeated somewhere else because there's a lot of small studies that say dose is very important. If we now move on to the whole idea of intermittent versus continuous. Is there an improvement? Here's some data that we generated under Augustine, published a number of years ago, with a fixed dialysis dose, given either as continuous therapy or as intermittent therapy, looking at a small number of patients, nonetheless prospective, randomized, and controlled. And notice that there was absolutely no difference in outcome, one form of therapy versus the other. So the format of therapy may not affect overall outcome. So as we move along and we look at other things, there's no data showing that there's any outcome difference in any of these things, with the exception of dose, which shows no outcome data. So it's a negative trial, which actually has a very important implication in the way we practice. Most comparisons are based on very small numbers of patients. Then also notice that the convection, which does favor middle molecular clearance, would have an advantage for middle molecule substances. However, if you were to do diffusion, which is basically dialysis, by changing the membrane, by having a more porous membrane, you can approach, if not exceed, the same middle molecular clearances that you would get with convection on a tighter membrane. So I think a lot of these controversies are sitting there that are going to generate new forms of therapy. One of the biggest controversial areas is this ultra-high flow for dialytic intervention, said to be applied to septic patients or to patients with ARDS. The whole concept here is a higher removal of middle molecules. But in any prospective study that's been shown, there's really not been convincing evidence that they add anything to improving the mortality or outcome in that subgroup of patients. Applications have also been involved in extracorporeal therapy for liver failure as a bridge to liver transplant, but there really has not been good application of therapy as a total support for end-stage liver disease. As a bridge also for cell therapy with the use of cells or other forms of issues or elements that are placed on the membrane to actively help in removal or processing, such as adsorption or proximal tubular cells, kidney proximal tubular cells. Also, isolating an organ, giving large doses of chemotherapy, having that system work through some sort of adsorber or remover of the toxin prior to the blood re-entering the system is also something that's under experiment. So when we look at all of this, say to ourselves, well, where is the role of continuous therapy? What can it do? Is it all controversy, or does it really have a role? I think if we sort of look at the therapy, we have the hemodynamic stability is absolutely superior. There's nothing else that can give the stability with extracorporeal therapy that continuous therapy does. I think volume control is made easier. We've seen this over and over again in all of our podcasts, but also in your clinical practice. Volume control, when you use continuous therapy, is a lot easier than it is with intermittent forms of therapy. Nutrition is virtually unlimited. And then finally, there's a refocus on the aspect of care. Should we start earlier? Should we start for systems beyond just the renal system? Are there other issues that we should be getting involved in with extracorporeal therapy falling into the realm of continuous formats? And if so, how do we handle that? How do we study that? And will that, in fact, bring with it an improvement in outcome for these unfortunate patients?